Okay, let's see here now. I think I am on live on Facebook. I'm checking my other computer because today we're going to do a quiz, which we do the last Thursday or the third Thursday of every month. Hopefully you are seeing us live. And so what I'm going to try to do is I'm looking at it's interesting what I'm trying to do, as you can hear me come in and out, is look at my desktop and make sure that I'm sharing with you on my other computer. And there it is. And there it is. And for now we're on the excellent quiz question. So, okay, what we're going to do is we're going to look at a bunch of cases. Hopefully we're going to show them to you correctly. And so let's get started with that. Hopefully I can advance my slides. And we're going to be looking at the spleen out of the first few cases. So I think I mentioned to you that I do a weekly quiz for our faculty. And what I'm trying to do is take some of the cases we discussed. We have an hour-long quiz section, so I only do this for about 15 to 20 minutes, but I thought I would share with you some of the cases and let you have the opportunity to be able to look at the cases. So this patient had left upper quadrant pain, and I'll show you just a couple scans, and what you see on the first few scans is the patient has a large spleen. And I will tell you the patient has sickle cell disease, sickle cell trait. Again, here it is. Spleen looks big. I don't see anything spectacular beyond the large spleen. Now here's where the patient comes in with abdominal pain. Now look at the spleen. The spleen is large, but there's hypodense zones around the edge of the spleen, and it kind of has a weird appearance. When you think about lesions of the spleen, you think about infection like abscesses, but those are small or large lesions, single or multiple within the spleen. You think about infarcts, those are peripheral wedge-shaped. You think about tumors, infiltration, but this is low density around the edge of the spleen. You see a little bit of irregularity of the splenic tissue, and you say, well, maybe I'm missing a subcapsular bleed, but subcapsular bleeds are usually pushing. They have mass effect on the spleen and splenic capsule. This doesn't have mass effect, and what you can really see is how it's around the edge. So now you say, what's going on? It doesn't look like infection, that's not the appearance. It doesn't look like tumor, that's not the appearance. Could this be a bleed? Bleeds can give you very strange appearances. Again, as I mentioned, usually it's compression, it's high density if it's acute bleed. But what's going on? Now I'll show you that patient 2 weeks later. Now look at the spleen. The low density areas have increased. The normal splenic tissue is markedly irregular. And I'm showing you a few different images really nicely, even with the cinematic. Remember, red tends to be fluid. And you see the defects, which in part you could think of infarcts, but the way it's around the host splenic tissue, the way it's in the periphery, and I'll show it to you there on the cinematic rendered axials. But look at the sagittal view. Look how it looks like a coffee bean, which is a spleen. But look at that low density around the periphery. And that's just a wonderful, wonderful example of splenic sequestration. And you saw it from the original large spleen. This patient had sickle cell disease. Get a big spleen. Often patients with sickle cell have splenic autoinfarction and they have a small calcified spleen, but it can be normal in size, can be large. But then you see as they experience pain and splenic sequestration, you see the low density. Just a beautiful, beautiful example of sequestration. Now, just to show you, you can sometimes see that again as another example, which I thought I blocked out, but there it is again, beautiful sequestration. Again, you could think of infarcts. It's kind of in that same category, but that peripheral, the fact that a substantial area of the spleen is involved, just a beautiful example of sequestration. Okay? There's an article written by Sheila and Satomi. This was mainly for ultrasound, but acute splenic sequestration, the sudden pooling of red blood cells in the spleen, is an emergent process typically seen in children with homozygous sickle cell disease. Splenic sequestration has rarely been reported in adults. This was an adult with heterozygous sickle cell conditions, including sickle cell beta thalassemia disease. Acute splenic sequestration results from the trapping or sequestration of red blood cells in the spleen of a person with sickle cell disease. Clinically, splenic sequestration crisis is defined as a drop in hemoglobin by 2G per DL in the setting of an enlarging spleen. Okay, great. Example, CT will show an enlarged spleen with a thick irregular rim of peripheral low attenuation representing infarcts and hemorrhage. Okay, alternatively, CT may show large and more diffuse areas of hypoattenuation within a large spleen. Again, one thing important, splenic artery and vein are patent, so it's really this sequestration. And again, the article worth reading talks about some of the other differential diagnosis, hemorrhage, infarction, but this appearance of the low density around the outside to me is just really spectacular. What a terrific case. Now, you could also look at a patient like this one who had pain in the left upper quadrant, and now you can see that the patient has severe pain, had a vague history of pancreatitis, and what you're seeing in this case is a large bleed in the left upper quadrant. This could be due to trauma. It could be due to patients with pancreatitis, which weaken the splenic capsule, can lead to aneurysms or pseudoaneurysms, and you can see a large bleed and spontaneous splenic rupture. So again, something to think about. So one of the things, and the reason I picked this series of cases to look at the spleen tends to not be thought of a lot. We talk about the spleen in trauma, of course, one of the things you worry about, but beyond trauma, we don't think about the spleen much. We think about it with infection, okay, abscesses, those splenic abscesses are rare. We think about it with infarction, patients with endocarditis. We think about it with vasculitis, infarction, but you got to think about sequestration. History is always important no matter what patient we look at, but particularly in the spleen, history becomes important. Now, what about this patient with weight loss and fever? You see large cystic splenic lesions and multiple hepatic lesions. Abscesses, let's say we think about that, but that'd be the largest splenic abscess ever. There's no free fluid, there's no peritonitis. Infarcts, no. Could it be a complex cystic lesion, but again, that's benign, but I guess it's a thought, but now I'm telling you there are liver and splenic lesions. When you have liver and splenic, it's not always malignant, right? Because sarcoid gives you liver and spleen, but this does not look like sarcoid in any way, shape, or form. And I have to admit the liver lesions and splenic lesions are irregular. Again, you can consider abscess, but what kind of abscesses is so large? I mean, you can get large abscesses, I know, post-op, E. coli, but for spleen, without air, 20% of abscesses have air, but when they get this large, they invariably have air. So now you got to say, what else could it be? Liver and spleen, you got to think about tumor. So if you said lymphoma, I would say that's a great idea. Okay, but this wasn't lymphoma. If you said this was metastatic melanoma, I would say excellent idea. Melanoma goes to spleen, goes to liver. But it's not that either. This patient had AIDS. Well, what else do you see in patients with AIDS? You see Kaposi sarcoma. Kaposi's is one of the tumors that gives you cystic metastasis in the liver and spleen. In the liver, cystic mets, you think about Kaposi's, you think about GIST tumors, you think about ovarian cancer, maybe melanoma. Spleen, you got to think melanoma. You could think of other sarcomas, and this was Kaposi sarcoma, a really excellent case. Now, let's move over a little bit. Now, one of the things people ask me to do when I do the quiz is to cover different areas, and so I gave you some spleen. I'm giving you now some kidney. This patient has hematuria. Look at the patient's right kidney. There's a complex cystic lesion. These are non-contrast. It looks like some rim calcification, upper pole on the coronal, but it looks like multiple low-density areas. With enhancement, you see those cystic spaces really well. Doesn't seem to be any true function within that cystic lesion beyond the septations, and it's kind of exophytic. The rest of the kidney looks good, and the contralateral kidney looks good. So what am I thinking of? Well, obviously, a kidney lesion, you always think about a tumor. You also think about cysts. Cysts are more common. This is obviously not a simple cyst. There are too many septations, and the septations enhance. If this is a cystic lesion, maybe it's a cystic renal cell with multiple septations. In cystic renal cells, you can see solid components, you see septations. Septations can enhance, but it's kind of funny looking. Now, I have to admit, the one thing you know here at the end of the day, this lesion is coming out, right? No one is going to follow this lesion. But I'm asking you, what are cystic lesions with septations in the kidney? Cystic renal cell, okay, I can't argue against that, but what other things are there? And here it is, you see the septations well on the excretory phase also. It almost looks like hydatid cysts with multiple daughter cysts, but hydatid cysts of the kidney does occur, but now without liver disease, and usually you see coarser calcification. So what are we trying to come up with here? And the answer was a MEST, M-E-S-T tumor. Now you say, what is a MEST tumor? So let me just tell you a little bit. If you put this lesion in the Bosniak category, this would be a 3, which you have to worry about malignancy. And the fact is, with a Bosniak 3, it's more than a 50% chance of malignancy. And it also means it's coming out. Now, one thing, when you think about it, this lesion would look like a perfect candidate for partial nephrectomy, which it was. Now, here's another example of the same diagnosis. Look at the image on your right. But differential cystic renal cell, but the two big things, multilocular cystic nephroma, or MCN, and a MEST tumor. And you think about it, there are other things, polycystic kidney disease, a dysplastic kidney abscess, some funny infection like XGP, but then the rest of the kidney would also not be functioning. XGP usually involves the entire kidney. I've seen a couple case reports of focal XGP, but I don't see a big stone here. So those are the three big ones. Now, multilocular cystic nephroma, it's rare, it's benign. Mets have been reported. It's older females. Pathology, solitary mass with cysts of varying size filled with serous fluid. And on imaging, there are multilocular cystic mass with thin septations with a tendency to herniate toward the renal pelvis. And here's just another example of that same diagnosis. Now, the MEST tumors, again, everything in this world is abbreviations these days, but is a mixed epithelial and stromal tumor. It used to be known as a mesoblastic nephroma or cystic hematoma. It's rare, again, loculated fluid collections. MCN and MEST are hard to distinguish from an imaging perspective. I think if you mention both of those, you're probably going to be right. But again, that differential diagnosis, I'm always worried, of course, about a cystic renal cell carcinoma. But in this case, as you know, and as we said, it's a minimum Bosniak 3, and the lesion is coming out. Okay, no problem, a MEST tumor. And here's another MEST tumor right here, large cystic lesion, cystic and solid components, kind of looking exophytic and well-defined. Again, if you've seen this, Linda Chu wrote an excellent article. It's worth reading. Really great case. Now, I was quizzing one of our faculty members yesterday, and Atif Zahir, who's outstanding, and I showed him this case after I showed him those MEST tumors. And you look at this non-contrast as a big renal lesion. It has more soft tissue component than the prior study. And he was making the point very much that I would agree with. This looks like a cystic renal cell. It's a big cystic lesion with solid components. You don't have the septations of the prior case. You have more solid component. But then I said, okay, that's a good thought, but that's not the answer. Well, what else could it be? Now, one of the things that we do see occasionally, but it is uncommon, is going to be things that come off the capsule of the kidney. That's exceedingly rare, but there are capsular tumors, there are sarcomas, and this was a synovial sarcoma of the left kidney. Now, I want to tell you that's a great diagnosis, and if someone's quizzing you and you see an exophytic mass, it's good to think of a capsular lesion. In real life, I don't think I've ever diagnosed a synovial sarcoma of the kidney. I haven't diagnosed it off the left kidney, and to tell you the truth, I haven't diagnosed it off the right kidney. Now, let me show you one more case. This is hematuria in a 17-year-old. Now, we always like to say that hematuria in younger patients usually is stone disease. Hematuria, but gross hematuria, a third of the patients, even under 35, will have an underlying cause like a tumor. So you see this mass in the patient's right kidney. It's vascular. And you're trying to say, well, what could it be? If the patient had sickle cell trait or sickle cell disease, you get medullary carcinomas. They're rare. They're also very aggressive and have mets. Here I just see the solid mass. It's vascular, so it's not an angiomyolipoma. What else could this be? Could it be a chromophobe adenoma? I don't know. It doesn't really look like that. It looks like a renal cell carcinoma, and the question would be, papillary versus clear cell. But at 17 years old, we think about younger patients with tumors under 10 or usually under 5. We think about Wilms. We think of nephroblastoma. If patient had a history like lymphoma, perhaps, or leukemia. But what was this? On path, it was a mixed papillary and clear cell. It was nothing very special. There's a really good article, and for some reason it's not showing the reference. It's about a year ago in Radiographics. Pediatric tumors that are common during the second decade of life, which is what this patient was, 17. Translocation renal cells, papillary renal cell, clear cell, medullary carcinoma, again, patient with sickle cell trait, angiomyolipomas, but then you see fat, metanephric adenomas, lymphoma, peanut, synovial cell sarcoma. Again, a differential, but I guess common is common, but we don't see many renal cells. Renal cell, however, is the second most common renal malignancy of childhood after Wilms. It's more common than Wilms in the second decade of life. So again, we like to think about pediatric tumors in pediatric patients, but 17, at the end of the day, classic renal cell is going to be more common. Again, translocation renal cells are worth thinking about. In the right population, renal medullary carcinoma is a good choice. Things like AMLs, you need to see fat. Now, the amount of fat in an AML will vary, but at least you want to think about it. So let me give you one bonus case, left upper quadrant pain. Now, I know I'm only showing you some images, not everything. You could say maybe it's pancreas, maybe it's from spleen, maybe it's retroperitoneum, from the mesentery, maybe it's kidney. Well, I'm telling you, this is from the adrenal. It's a cystic lesion with what look like fluid levels in it. Well, what could this be? Now, I've showed you a number of adrenal lesions over the past few weeks. I gave you a talk is coming up, a 4-parter on large adrenal lesions. Well, this was, and you think of cystic lesions, well, maybe it's a primary adrenal cortical carcinoma. That's a good thought. Maybe it's a MET. Patient had no history of primary. What else? Hemorrhage, that would be a thought. Hemorrhage can give you all sorts of funny appearances, but the patient was not on anticoagulant therapy, had no history of trauma. Of course, you can have things like adenomas that bleed. That would be a thought. Well, this was a pheochromocytoma. Remember I've said to you pheochromocytomas can be cystic. This is a beautiful cystic pheochromocytoma with septations. It's uncommon, but it does occur. And for the last case, to finish with adrenal, this is a large mass in the right kidney. What is it? The calcifications to me are important. You can have calcifications in myelolipomas. You can have calcifications in prior bleed. You can have calcifications of the adrenals with TB or blastomycosis. But dystrophic calcification in a large mass to me is always concerning, and I'm concerned this patient has a malignancy. Mets typically don't calcify. When you have calcification, you better be thinking about a primary adrenal cortical carcinoma, which this indeed was. So again, solid mass, dystrophic calcification, large, think of primary adrenal cortical carcinoma. So I've given you maybe 8 or 9 cases. I hit on some adrenal cases. I hit you on some splenic cases. I hit you on some kidney cases. So hopefully that'll help you with differential diagnosis. Let us know if you like the cases. Lily has told you that we're doing it every Thursday, every third Thursday of the month. So we do about 4 or 5 weekly sessions a month. We're doing one of these on cases. So let us know. And with that, I thank you for your attention. And I'm going to escape. And now we're basically going to go and I'm going to end live video and